the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I'm Kelsey Morrow, and I'm the Education Manager at the Rocky Mountain MS Center. And I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to EMD Serono, Genentech, and Novartis Pharmaceuticals. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Some of the most recent videos that we've posted are the presentations from the Fall Education Summit, which covered the differences and similarities between NMO and MS, research updates, addressing mobility concerns, the concept of PURA, and cognition. There is also an archive of videos from a series called Conversations on MS, which is a 90-minute town hall style Q&A with MS specialist neurologists from the Rocky Mountain MS Center. It includes a clickable index of topics discussed during that session. We have several more webinars coming up on managing the financial risks of disability and cognitive function in MS. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested, but if you would like to monetarily support the MS Center, we have Colorado Gives Day on December 5th, or you can donate at any time at mscenter.org. Today's presentation is about demystifying MRIs. Our presenter is Dr. Justin Honce. Dr. Honce is a neuroradiologist specializing in MS imaging at the University of Colorado Anschutz Medical Campus. He works closely with the neurology team at the Rocky Mountain MS Center at University of Colorado to optimize MR imaging in MS and serves as MR Medical Director and Vice Chair within the Department of Radiology. This webinar features a lot of important information. If you missed something on a slide or want to hear it again, we are recording this webinar and it will be archived on our website at mscenter.org, so you can replay it at any time. All live viewers will also get the recording automatically sent to them. You will also receive a link to our evaluation survey. Please take a few minutes to fill this out as it helps us improve future programming. We'll reserve time at the end to answer questions from the audience. You can submit those questions at any time, though, using the Q&A box on Zoom. We'll answer as many as time allows. Today's presentation is for educational purposes only. With that, we'll turn it over to Dr. Honce.
Thanks, Kelsey. You guys can all hear me?
Yep.
Perfect. Thank you so much for that warm introduction. I'm really excited to be here. I've been with the University of Colorado at Anschutz Medical Campus since 2012 when I completed my fellowship in neuroradiology. And in my second year of neuroradiology, I spent a lot of time actually within the MS Center at Anschutz, working with people like Dr. Koboy, Dr. Alvarez, Dr. Volmer when he was there, even Dr. Miravalli before he left. And it was a great experience to be able to work with such wonderful neurologists who really working to take the best care of patients as possible. Let me start my presentation here and we can get going. Perfect. So the title of the topic today is MRI Demystified, a patient's guide to MRI imaging in multiple sclerosis. I have no disclosures relevant to the content of this talk. So here's the basic plan for what we're going to go through in the next 45 minutes or so. I'm going to start off by giving you an overview of what MRI actually is. We'll talk through how it's different from other imaging modalities like X-rays and CAT scans. We'll show you what an MRI machine is made of and then discuss how it can create these amazing pictures that you can see of your brain, your orbits, and your spinal cord in patients who have MS. Then we'll talk about when and how often you should be getting an MRI in MS and talk through issues related to MRI contrast. It's important to know what to expect when you go for an MRI. So we'll touch on the importance of MRI screening as well as hearing protection for the scan, as it can be quite loud in the scanner. We'll then review the various MRI sequences that are useful in MS and discuss the diagnostic criteria that we use to diagnose and follow MS patients over time, looking at classic imaging features along the way. Lastly, we'll touch on advanced techniques that are beginning to move from research world into clinical practice, things like the central vein sign, so-called peripheral rim lesions, and brain atrophy and volumetric analyses. Lastly, we'll do a Q&A and answer any questions you might have. So, when radiology first got started almost a century ago, all we had were X-rays. X-rays are only able to differentiate between tissues of very different density. So in an X-ray of the head, as we can see here, you can see differences between bone, soft tissue, and air, but we can't see much of the brain itself. CT or CAT scans changed all that. By putting a spinning X-ray emitter around you and spinning it really, really fast in a circle, a CT scanner is able to reconstruct images of the inside of your body in much greater detail than a typical X-ray. We can see how the brain itself how that differs from the low or dark fluid that you see along the margins of the brain and within the ventricles. You can see the difference between that, bone, muscle, and skin. But CT scanning is still X-rays, so it depends solely on differences in tissue density. So it's hard to see differences between the various parts of the brain itself because the brain itself is really very nearly one density. This is where MRI completely changed the imaging landscape. MRI allows us to see tissues and differentiate them based on their underlying tissue microstructure, not just their density. As such, it's way easier to see the brain anatomy and pathology. And this is quite clear here, right? The X-ray looks normal, the CT looks near normal, but the MRI shows just how much white matter damage there is actually going on. So, what is an MRI machine? The secret sauce is actually right there in the name, magnetic resonance. So there's two major components to a scan. The first word is magnetic, and an MRI machine contains an ultra powerful electromagnet within the walls of the scanner that creates a very, very, very strong magnetic field. The second word is resonance, which in this case relates to radio frequency signals. What MRI uses is a series of coils to send radio frequency energy into your body and listen for emission of some of that energy back out. And the difference between what went in and what went out allows the computer to reconstruct the images themselves. Radio frequency transmit coils are within the bore or wall of the magnet and transmit or send the energy into your body. The gradient coils, which are also within the wall of the scanner, help the MRI machine know what part of the body the signals are coming from and going to. And it is these gradient coils which create the sound that you hear when you're in a magnet, which we'll talk about later. And lastly, the receive coils, which are typically that cage that gets fitted over your head, or the devices that either lay on top of your body or underneath your body, depending on what part of the body is being scanned, that help to listen for the signals that get sent back from your body. So what's important to know about the magnet part of MRI? The first thing to know is MRIs come in various strengths. 99% of the MRIs that you're going to see or experience over your life as a patient are going to be either what is called 1.5 Tesla or 3 Tesla, where Tesla is an indication of magnet strength. However, other strengths are also found in some rare circumstances. Open MRIs have fairly low strength. The lower strength means potentially decreased image quality, but some patients prefer this given the claustrophobia that is common in a typical bowl or kind of tunnel-shaped magnet. There are stronger magnets as well, up to about 7T as the strongest clinical magnet available today in some institutions, but these are pretty rare so far. They really have superb image quality due to how strong the magnet is. And how strong are these magnets? A typical MRI is 1,500 to 3,000 times stronger than a standard kitchen magnet. If you think about stronger magnets like junkyard magnets, which are capable of picking up a car, those are close to 1 Tesla. So an MRI is even stronger than something that can pick up a car. But remember, just based on the numbers, you may think, hey, a 3T magnet must be twice as strong as a 1.5T magnet, or a 1.5T magnet is just 50% stronger than a junkyard magnet that would be rated at 1T. But actually, every time you double Tesla, you're actually 4xing the magnet strength. So an MRI is by far the strongest magnetic field you will ever experience in your life. The other thing that I really want you to remember about the magnet part of MRI is that the MRI is always on, never off. Doesn't matter if it's scanning or not scanning, doesn't matter if you show up in the middle of the night or what. The magnet is always on, always running. And so it's really, really important that you keep close attention to this as a technologist and a patient and not bring things in because you can have very bad incidents happen, such as this example of where a bed was sucked to the magnet. Luckily, no patient was involved. So how do these magnets help us see into your body? It all starts with protons. Protons are tiny molecules in your body that spin. And because they are charged particles, they're actually really tiny magnets. And the arrow in this case shows the direction of the tiny magnetic field generated by that spinning proton. If you were to look at the spinning proton in your body as you walk down the street, they'd all be pointing in different directions and overall canceling each other out. But when you put yourself and all your protons into a large magnet of the MRI, which has a very strong direction of the field, all your protons line up in the same axis of the field, most of them pointing in the direction of the MRI field. And now that they're lined up, we can talk about that second part of MRI, the resonance part of MRI. So your protons in the MRI are all happily spinning aligned with a magnetic field. And those radio frequency transmit coils send signals into your body. And this energy is absorbed by those spinning protons and it knocks them off axis. So instead of pointing with the field, they're pointing perpendicular. And over time, they start to flip back and start pointing back. And when they do so, they release small radio signals. And the time it takes for them to flip back, how quickly they do it all depends on the specific tissue microenvironment around these protons. If they're in fluid, they flip back quicker. If they're in bone or fat or an MS lesion, they may take more or less time to flip back. And so the receive coils listen for the return of that tissue, and the gradient coils help figure out where that signal is coming from. And the MRI then uses all this information to construct the final images. And the images that MRI can create really are quite beautiful, and they allow for amazing high-resolution views of your anatomy and structure. In MS, we look mostly at your brain, your spinal cord, and your orbits, but they can image any part of your body you want. But before we get into details about these specific sequences, we first need to talk about how often should you really be getting an MRI with MRI in MS in the first place. So when you have symptoms for the first time, your doctor will order a baseline MRI scan. This may be of the brain, it may be of the spine, or it may be both, depending on what specific symptoms originally brought you to the doctor. This baseline MRI may or may not be able to give you a diagnosis immediately, and a new MRI should be obtained, roughly speaking, every 6 to 12 months until a diagnosis can be made. After a diagnosis can be made, usually there's a decision about whether or not to institute treatment. Since any medication you get started on will take a few months to start working effectively, it's important to get new baseline scan about 4 to 6 months after starting your medication. This will serve as the baseline study comparison to see if you develop new lesions on subsequent follow-up imaging to make sure that the treatment you're on is working. Generally speaking, follow-up MRIs are done on a yearly basis, and that's considered standard. But if you are clinically stable for several years, often your doctor may consider longer intervals for subsequent care, every 2 years, every 3 years, etc. If you have a relapse, your doctor may do scans sooner than once a year in order to see if that clinical relapse that you're experiencing corresponds with new lesions on your MRI. Spine MRIs are generally obtained less often, every 2 years or longer, as lesions in the cord are almost always symptomatic and usually aren't missed. But if you do have a relapse that might be from the cord, your doctor will order MRI more frequently. How about MRI contrast? Do we need it? In multiple sclerosis, contrast is used to identify lesions that are enhancing. These enhancing lesions indicate areas of active or acute inflammation, and specifically areas where this inflammation has damaged the blood-brain barrier and allowed contrast to leak into the central nervous system. Contrast is super helpful when trying to diagnose multiple sclerosis early in the disease course. It is also helpful when you have a new relapse or if you have a change in treatment to see if any area of active or acute demyelination inflammation are present. Contrast, however, is not necessary at all for routine follow-up imaging that you just get on a standard yearly or every 2-year basis. On typical follow-up imaging, we are looking for new lesions to indicate progression of disease, and we can do that just fine without the administration of contrast. The safety of MRI contrast has been a topic of concern to a lot of patients, and I think we should spend a little bit of time talking about it here. So, and to do that, you really need to understand kind of what MRI contrast is. So, MRI contrast contains a rare earth metal called gadolinium. It's actually on the periodic table. The molecule, which is chelated or bound to the rest of the contrast agent, and the combination of the agent itself and the gadolinium ion that is bound to it is called a gadolinium-based contrast agent, or GBCA. The binding of gadolinium ion to the contrast agent is either linear, where the molecule is only partially surrounding the gadolinium ion, as you can see in this picture here, or macrocyclic, in which the molecule completely surrounds the gadolinium ion. As you'd expect, given the binding types, macrocyclic agents tend to be more stable than linear agents. That is, the gadolinium ion has a harder time escaping from the contrast agent from macrocyclic agents as compared to linear agents. Back in the early 2000s, you may have heard of a disease that was discovered called nephrogenic systemic fibrosis, which is a very severe disease that happens specifically in patients who had kidney disease or most severely were on dialysis when they were given very specific gadolinium agents. When radiologists discovered this disease, there's a lot of work done. New workflows were created to prevent these agents, these specific agents, from being given to patients with kidney disease or dialysis. The current gadolinium agents that we use in the United States are not those agents that were associated with NSF and really don't result in NSF even if you have kidney disease or on dialysis. And the work that went into trying to figure out what NSF or nephrogenic systemic fibrosis was and stop it has been incredibly successful. There has not been a case of NSF worldwide since 2012. And since in the USA, there has been no case that has occurred since 2010. Most recently, though, and something you guys may have heard about, is that it's been discovered that even if you have normal renal function, there is a very small amount of gadolinium that appears to escape the contrast molecule and deposits within brain tissues. This happens even if you have normal renal function. We know this deposition is dose dependent, i.e., the more gadolinium you get, the more that gets deposited over time. We also know that in general, macrocyclic agents tend to have less deposition than linear agents. Despite this documented deposition and lots of research, no confirmed adverse effects of this deposition have been discovered. Ultimately, from my perspective, the benefits of gadolinium administration in MS and many other diseases really does outweigh the theoretical risk of adverse events, which we haven't seen. But it's really important to remember that it should only be used when the contrast has a good chance of a true clinical benefit. We don't want to administer it if it's unlikely to change clinical management. So if you've had MS for years, you've likely noticed that we mostly don't give contrast to patients with MS these days, and really only do so when patients are being diagnosed and sometimes after relapses or changes in therapy, as we know those instances are the instances where contrast has the best potential benefit. But we really shouldn't and generally don't give contrast at all for routine follow-up imaging. So ultimately, even though there's no confirmed adverse effects of this deposition, we still really want to minimize deposition out of an abundance of caution at the very least. All right, so let's talk about preparing for an MRI. The most important thing that needs to happen every time you have an MRI is that you need to be screened for the presence of devices, foreign bodies, shrapnel, etc., to make sure whether it's safe or not for you to have an MRI. And this is done by completing the MRI screening form, which is a ton of questions, and it's actually pretty time consuming. So it can be difficult sometimes for patients to fill it out. But it's really important that this gets filled out accurately, and it has to be done every single time you have an MRI. Because something might have changed since the last time you had an MRI, and we wouldn't know that. As you already saw, right, magnets are very strong. And if you have something within your body that might move or dislodge, things like, for instance, an aneurysm clip, or maybe an electronic device like a stimulator or a generator, there's a theoretical possibility of the MRI damaging the device, causing it to be needing to be replaced, or malfunctioning and causing injury. And if there are wires or wire-like materials in your body, these can heat up, and that heating can lead to burns in cases, and we don't want that to happen. So depending on what kind of device or thing you have within you, you might not be able to have an MRI scan. But in most cases, you probably can in one way or another. In some cases, it may be safe to scan one part of the body and not the other, depending on the exact device implant and its location. Sometimes it may mean that you can still have the scan done itself, but the scan has to be done in a different way, either with fewer sequences or perhaps using less energy to reduce the risk of harm. Ultimately, the decision about if you can have a scan or not will be decided by the radiologist who's in charge of the MRI. In my role as medical director, we get calls all the time from technologists saying, hey, we got a new patient, they have a stimulator, they have this, they don't know what it is. How can we do that appropriately? And then myself and our physicist work together to figure out the best way that we can say yes, because we really want to say yes to patients as much as possible, but we want to do so in a safe manner. The next most important thing to remember about an MRI is it's crucially important for, keys, phones, scissors, or any other metallic devices need to be removed before you get into the MRI. And this makes sense, right? MRI is a strong magnet. We don't want to have things flying across the room and possibly injuring people when you enter an MRI. You should also be changing into gowns before an MRI and not having an MRI in your street clothes, generally speaking. It may not make perfect obvious sense when you first think about it, but it's quite important actually. Some clothing will actually cause artifacts. Some clothing now has metallic fibers in them, and this can result in burns. And then even more simply, taking off all your clothes, putting on a gown makes it easier to ensure you haven't forgot your keys, your phone, or anything else in your pockets when you go in for a scan. Jewelry also needs to be removed, and some types of hair extensions can also be a significant problem. Some extensions, jewelries can't be easily removed, and your technologist may test them with a handheld magnet to see if they might be safe to keep them on, but it is possible if they're not removable that it may not be possible to have an MRI. Those gradient coils we talked about that help the MRI figure out where in your body signals are coming from are quite noisy. They actually vibrate very similar to the way a speaker vibrates, and that creates the sound you hear. And I'm going to play a little bit of that sound right now just so you guys can hear it for anyone who might not have had an MRI yet. And it might be a little... That's loud, right? The noise levels in an MRI can be up to over 100 decibels, which is actually kind of like being in a construction site sitting next to a jackhammer. And that sustained exposure to that level of noise can cause hearing damage. So hearing protection during an MRI is really, really, really important. And there's usually two parts to proper hearing protection. The first are earplugs, as you can see here. And the second are headphones that can be added as an additional layer of insulation depending on the type of earplugs that are used. For earplugs, as I'm sure anyone who's had an MRI knows, it can be really hard to place those properly. And I hear a lot of questions from patients and technologists about how you know that the earplugs are in. And from my experience and from what's recommended in the literature, the best thing to do is to do something called the finger rub test. So the next time you go for an MRI, when you put in those earplugs, just take your fingers, put them next to your ear, and rub those fingers together. And if you can hear your fingers rubbing together with your earplugs in place, they're not placed correctly, and you should replace them. And doing so will really make the experience of being in the MRI a lot less difficult, at least from a sound perspective. So how about the scan itself? Depending on the scan that you're getting, you can expect to be in the MRI for about 50 to 90 minutes or so. The more parts of your body that are being scanned, the longer the overall time needed for that scan. And also 1.5T imaging tends to take a bit longer than 3T imaging generally. This video gives you a sense of what an MRI can feel like if you haven't had an MRI scan yet. With the head coil in place, which you can see her placing around the camera, you can really feel quite claustrophobic, right? And claustrophobia is very, very common in the MRI. So don't feel bad if you know you're going to feel anxiety from these scans. It's something that is completely expected and can be very difficult for patients. So if you know you're going to feel this, consider talking to your doctor about getting some meds to help you feel more relaxed. And one of the reasons it's important to stay relaxed is because it's important to stay still. Staying still during the scan is very, very important. Motion artifact causes lots of problems in MRI and can make lesions harder to see. As you can see here, where the lesions in the right side of the patient are actually pretty hard to see and a lot more difficult to see than on the scan that doesn't have motion artifact. Lastly, when you're in the MRI, always alert your technologist if you feel pain, burning, strange sensations, etc. We really want you to be able to talk with us and tell your technologist what you're feeling because that helps you stay safe when you're in the MRI scanner. Okay. What about sequences? So if we're going to talk about sequences, the first thing that you need to understand is what different kind of images we actually create in terms of the way we show them. And the planes of imaging are called axial, coronal, and sagittal. In the axial plane, we slice you into a top and a bottom half. And so when you're looking at an axial image, you would imagine that the patient is lying on a table and you're looking at them from their feet. And if you do so on that axial image, the right side of the body is the left side of the body. The left side of the body is the right side of the body. The top of the image is anterior and the bottom of the image is posterior. In the coronal plane, we slice you into an anterior or front and posterior or back portion. And when you're looking at a coronal image, you want to imagine you're looking at the person in the eye. So again, the right side of the image is the left side of the body and vice versa. In the sagittal plane, we slice you into kind of a left and a right side, and you look at the person like you're looking at them from their side. So the left side of the image is the front and the right side of the image is the back. So let's dive into the individual sequences we acquire and what they help tell us about multiple sclerosis. So multiple sclerosis lesions are best seen on sequences with what is called T2 weighting. These T2 weighted sequences are considered fluid sensitive in that fluid and fluid-like materials will appear hyperintense, bright, or white on these images. And this lets us see edema, gliosis, and other damage related to demyelinating disease. On a standard T2 sequence, as you can see here, the CSF appears as bright white, which is both centrally within the ventricles and along the surfaces of the brain and within the sulci. And when you look at the parenchyma in this case, you can see small, bright lesions within the parenchyma corresponding to the demyelinating lesions, which we see due to the edema and fluid within the lesions themselves. The issue is that it's actually a little hard to see the lesions because of they're somewhat overpowered by all that bright signal that is coming from the CSF. And that's why the workhorse in MS is something called T2 flare imaging. T2 flare imaging is also known as fluid attenuated inversion recovery imaging, which is a T2 weighted sequence, but we have removed the signal from the CSF. And in doing so, this makes the lesions kind of pop more. They make them much easier to see. And so as a radiologist or a neurologist, when you're looking at these scans, you're spending most of your time looking at this T2 flare image to see all the lesions. Additionally, for brain imaging, we will do sagittal T2 flare imaging, as it makes it very easy to see the most classic feature of MS, the so-called Dawson's fingers, which extend from the margins of ventricles, which we'll talk about in more detail in a bit. One of the other really common presentations of patients with MS is optic neuritis or inflammatory attacks of the optic nerves. So it's really important that we have high quality orbital MRI in patients with MS. The nerve and the T2 bright signal within it during an episode of optic neuritis is again best seen on T2 weighted sequences. But unlike the brain, where T2 flare is used to get rid of unwanted CSF signal, in the orbit, we want to get rid of the bright fat signal around the nerve. So as you can see in this image here, you can see the orbit itself, you can see the nerve going back, and there's a lot of bright signal posterior to the globe, posterior to the eye, which is the bright signal, the fat. And so we use T2 FATSAT, or something called STIR, short tau inverted recovery imaging, to get rid of that fat signal. And when you do that, it makes the T2 hyperintensity of the nerve much easier to see. Like you can see in this image here, where the left optic nerve is large and T2 hyperintense compared to the more thin, dark nerve on the right side. The brighter signal at the margins is the CSF, which actually gets into the optic nerve sheath around the nerve. Also in the orbit, as opposed to sagittal imaging in the brain, coronal imaging is our standard in order to see the optic nerves. And you can see here again, the bright swollen left optic nerve compared to the small and more normal appearing right optic nerve. How about in the spine? So again, if we're thinking about lesions, we're thinking about T2 weighted sequences, right? T2 weighted sequences are going to be the best way to see demyelinating lesions in the cord, as you can see in this patient with a lesion within the cord at the C3 level. Again, though, standard T2 weighted sequences tend to make lesions a little bit less conspicuous because of unwanted signal either from the fat, which you can sort of see in the back of the neck here, or from the CSF around the spinal cord itself. And so again, similar to the orbits, we use T2 FATSAT or STIR, short tau inversion recovery images, to remove the fat signal. And this improves conspicuity of the lesions. The lesion in the cord is easier to see on the STIR image. Some places will also do what's called proton density images, which are actually even more sensitive than the STIR images for picking up these lesions. But they're also more prone to artifact, as you can sort of see in the lower cord here. There's a lot of inhomogeneity. In this case, you can really easily see that original lesion that you can see on the other sequences, but the proton density sequence lets us see maybe a second lesion up higher, kind of right below the skull base, that you are really hard to see, if not impossible to see on other sequences. We use axial imaging in addition to kind of corroborate what we see on the sagittal sequences. If we're sometimes wondering, is the thing we're seeing real or is it artifact? We can look on the axial imaging and say, no, I see it on both. I'm pretty sure it's real. So that's T2 weighted sequences. Now we'll talk about the other major sequence that we're using in MS, and that's the T1 weighted images. As compared to a T2 flare image, which we saw previously and you can see again here, The T1 weighted images are not fluid sensitive and are good for structural detail and assessing atrophy because they're sensitive to larger molecules and tissues, things like blood, fat, and protein. And so a T1 weighted image, as opposed to the T2, will look like this. And one of the things that pre-contrast T1 weighted images are really good for are showing the so-called T1 black holes that you can see in MS. And if you've ever wondered what a T1 black hole is, the T1 black hole is the dark area of the lesion seen on a T1 weighted image. And what's important is the darker that T1 hole is, the more damage there has been to the axons in that location. So the more severe the damage. So a lesion that has a really, really dark T1 black hole like this, or maybe like this, versus some of the other T1 black holes, which are not as dark, are areas of more severe damage. And the more of these dark T1 black holes you have, the greater the overall damage, and usually the greater overall disability that you are experiencing. T1 imaging is also obviously really important for looking for contrast enhancement. So here is a post-contrast image. You can see enhancement with some of the vessels along the margins of the brain, but the lesions themselves do not appear to enhance in this case. This, however, shows you nice examples of what enhancing demyelinating lesions will look like. So these demyelinating lesions that are enhancing are areas of acute or active demyelination and active breakdown of blood-brain barrier where the contrast is leaking into the brain tissue. And the enhancement pattern in MS can have a lot of different views. It can be solid and nodular, as you can see with the lesion anteriorly on the front side. It can be a ring enhancing lesion, as you can see more posteriorly, or it can be more kind of faint, kind of fuzzy enhancement, as you can see in that lesion on the left. The one other thing I would say about enhancing lesions is that a typical lesion, when it first shows up, starts enhancing early in the disease, but usually stops enhancing about 6 weeks or so after it started. So if you see an enhancing lesion, you can be confident that lesion developed in the last month or two. How about the orbits? So just like in the brain, T1 imaging is good for structural detail and is used to look for abnormal enhancement, demyelination within the optic nerve. As opposed to the T2 fat saturated images, you can see on post-contrast T1 imaging, again, just like on the standard T2, there's a lot of abnormal signal, not abnormal, but bright signal posterior to the globe, which relates to the orbital fat. And that fat makes it hard to see the enhancement they want to see. So we also do fat saturated post-contrast T1 imaging, which makes the enhancement of the nerve much, much easier to see, as you can see here, where the left-sided nerve looks brighter and more irregular than the normal right-sided nerve. Again, in the orbit, we love coronal imaging as well, and that's true for post-contrast T1 sequences as well, again, with that abnormal enhancing nerve on the left and the normal appearing nerve on the right. Similarly in the spine, T1 again is great for structural detail. Compared to the stir images or the proton density images where you see the lesion very, very well, a T1 lesion makes it, without contrast, makes it very, very hard to see lesions. And we don't spend a lot of time looking at a pre-contrast T1 for lesions because they're just hard to see. But when you give contrast, any lesion that enhances becomes very, very, very obvious on imaging. And you can show that those areas have the acute active inflammation. They're recent, they're angry, and are related to new lesions. Okay, so now that we understand the sequences that we're using in MS generally, let's look at the diagnostic criteria for relapsing remitting MS, which are included within the McDonald criteria. And based on MRI, in any patient with a new clinical attack, we want to see if the lesions meet two criteria. One is, do the lesions meet criteria for something called dissemination in space? And one, asking if the lesions meet criteria for dissemination in time. To meet dissemination in time, lesions need to be seen in 2 of 4 areas of the central nervous system. These compartments or areas are as follows. You have the periventricular lesions, which are lesions along the margins of the ventricles, the edges of the ventricles. You have cortical and juxtacortical lesions, which are lesions that are within or touching the cortex of the brain, which is superficially at the edges. And then you have infratentorial lesions, which are below the tentorium, involve the brainstem, like you can see this lesion in the posterior medulla or within the deep white matter of the cerebellum. Finally, spinal cord is easy, lesions within the spinal cord as well. So if you have at least lesions in 2 of 4 of these spaces, you meet criteria for dissemination in space. How about dissemination in time? So the first and easiest way to meet criteria for dissemination in time is to do it with 2 scans. And if you have a new lesion that appears on a follow-up scan, you can say, yes, this patient meets criteria for dissemination time. And we can see that quite nicely here. We have multiple lesions bilaterally, but the T1 or follow-up image does show a new lesion indicated by that red arrow. But what if you just had the T1 side and you didn't have that baseline scan? Can you make a diagnosis of MS using dissemination in time based on a single MRI? And the answer is yes. If you have on a single MRI that has contrast, you can say, are all my lesions enhancing or some enhancing and some not enhancing? And if you have some that are enhancing and some that are not enhancing, they must be of different ages. And then it would still meet criteria for dissemination in space. So this is why one of the reasons why contrast is so important when trying to diagnose MS, as it lets you do so on a single MRI scan rather than needing a follow-up another 6 to 12 months, which would delay starting therapy for at least that amount of time. The McDonald criteria, diagnostic criteria for primary progressive MS are slightly different than for relapsing remitting MS. The first thing is, rather than looking for a new clinical event, you want to have confirmed 1 year of disability progression. And if you do have that, you need to meet 2 or more of the following criteria. The first is something we already talked about, dissemination in space. But the difference in primary progressive MS is you only need a lesion in one of those 4 compartments, not 2. Or you can have 2 or more spinal cord lesions. Or lastly, something that's actually not imaging related, you have your CSF tested and it has oligoclonal bands, which indicate inflammation within your CSF. So what does MS look like classically? What imaging features make us quite confident a patient has MS and not some other disease like the leukodystrophy, chronic white matter disease from atherosclerosis, or other disease processes? By far the most classic feature is Dawson's fingers, which are these finger-like extensions that extend perpendicular to the axis of the ventricles, as you can see here labeled by red arrows. These are the most classic and easily recognized MS lesions. And if you have lesions that look like this, the chances that you have MS are quite high. Other lesions that are commonly seen and can suggest a diagnosis of MS include lesions along the temporal horns or the atrium of the lateral ventricles, as you can see here with red arrows. These are not as commonly seen in other disorders. And so if I'm a radiologist reading a scan, they raise my concern that, hey, maybe this patient has MS. MS also very commonly involves the corpus callosum, which is this connection between the individual hemispheres. And a lot of times you'll see lesions along the inferior surface of the corpus callosum along the so-called callosal septal interface. Very common in MS, much less common in other disorders. When MS lesions are within the brainstem, they're more often peripheral than central, and also like the margins of the cerebral aqueduct, as you can see in the screen left image here, or along the 4th ventricle, as you can see here labeled by red arrows. Spinal cord lesions in MS also occur, obviously, and they have a fairly typical appearance that is less frequently seen in other disorders like neuromyelitis optica, transverse myelitis, MOG, etc. Typically, MS cord lesions are located in the peripheral rather than the central white matter, as you can see on these axial images where they're in the left side of the cord, not in the middle of them. And they tend to be relatively small in size, less than about the length or height of a vertebral body. If lesions are very large or central in location, it makes me as a radiologist think of other diagnoses, but it doesn't totally exclude MS. So, when MS patients come in with classic disease, it's really easy, right? It's easy to say, hey, this is classic disease. They have enhancing lesions, they have Dawson's fingers, et cetera. I think the patient has MS. But ultimately, the imaging spectrum of MS is much more messy and at times can be difficult to determine if a patient might have MS when the disease pattern isn't classic with standard imaging sequences. All these patients that you see on these MRIs, they all have MS and they look really, really different, right? Some of them are more typical, more classic, like the one in the top right and the bottom right. Those look a little bit more like MS, but other ones, much more non-specific and a little bit more difficult. So what can we do in radiology to help make diagnosis in cases where things just aren't as straightforward as I'm sure many of you have experienced in your road through MS? One of the most interesting ways to do this relates to looking for something called the central vein sign. So we know, based on the pathophysiology, that MS is a perivenular disease. What this means is that inflammatory cells move from the veins into the CNS and attack the adjacent tissues like the white matter, which causes the demyelinating lesions. When you look at specialized sequences called susceptibility weighted sequences or GRE sequences, you can see these veins. And there are a group of veins which are called medullary veins, which are these little, you can see as these little thin dark lines radiating away from the margins of the ventricles perpendicular to the axis of the ventricles. And it is this venular anatomy which makes Dawson's fingers the classic imaging finding in MS. These fingers are areas where there has been perivenular demyelination that occurs when the inflammatory mediators leave the medullary veins and attack the adjacent white matter. And in patients with MS, if you look at their lesions on these susceptibility sequences, you can see that these lesions often will have a central vein within them. Studies have been done to say, hey, okay, we think central veins are pretty common in MS. Just how common are they? And what they found is, in MS, somewhere between 20 to 40 to 50 to 60% of MS lesions may have a central vein, as you can see really nicely in this case with the lesion and then an axial, sagittal, and coronal reformate where you can really clearly see that central vein within it. So again, the inflammatory mediator markers are leaving that vein and causing demyelination around that vein. But that the central vein is not as commonly seen in other disorders like lupus, migraines, NMO, et cetera, et cetera. It's important to realize, though, that this isn't perfectly discriminatory, right? Random lesions from migraines or atherosclerosis, et cetera, may have a central vein just because of randomly where the lesion first showed up. But the more central veins you have within your lesions, the more likely you are to have MS, and this can help your neurologist and radiologist kind of make a diagnosis. On the same sequence where you look for central vein, you can also look for what's called peripheral rim lesions, which are, when you look at the T2 flare, you can see a bright lesion. But when you look at the SWI sequence, you say, hey, the edge of this lesion seems to have a dark rim around it. And if you have a lesion that has a central vein and it has a dark rim around it, the specificity for diagnosis actually gets right near 100%. Unfortunately, the sensitivity is still low in like the mid 20% range. But as PRL, as this kind of technology gets more and more research and more kind of application in clinical practice, we'll find that it's going to be used more and more to help diagnose MS in difficult cases. So lastly, before we get to the Q&A part of the talk, let's talk a little bit about brain atrophy. What do we know about atrophy? First thing we know is that atrophy happens even in healthy people, happens at about a rate of 0.2% a year after your 20s or so. But in MS, this atrophy rate is much higher. It can be up to around 1% or greater in cases of severe untreated MS, but is more typically kind of in that 0.5, 0.6% range. It's also clear from this graph, for instance, that there's a lot of overlap between the atrophy rates in healthy controls and MS patients. But the accelerated volume loss that you see in MS patients is occurring for a number of reasons. There's damage to the neurons and damage to the axons from the lesions themselves, as well as just ongoing background neurodegenerative processes that are just diffusely damaging your CNS and causing atrophy. We know that this atrophy is progressive. We know that it occurs right from the earliest stages of MS, like right in the first few years, you can see atrophy. And we know that brain atrophy actually correlates better with overall symptom severity and disability than just your lesions alone. So if you're just thinking about lesions, you're not going to fully capturing the complete picture of the disease. So clearly, atrophy is a very important process that we should be monitoring. The issue is that up until a few years ago, atrophy really could only be measured qualitatively. I, as a radiologist, would look at a scan, and if the bottom row was the scan I was looking at, and I would compare it to the prior, I would say, hey, the ventricles are bigger, the sulci are bigger. So this patient has had interval mild atrophy, moderate atrophy, severe atrophy. The problem is that's really a guesstimation. There was no real hard rules or way to be quantitative. And so it was hard to track this kind of thing over time. Today, there's numerous companies that have software that can take images from an MRI, analyze them in the cloud, and segment out the different tissues and even the lesions so that you can see exactly kind of what your brain volume is approximately. When this is done, they create very, very nice reports that you can find usually within packs. If you look at your images, showing your brain volume, as you can sort of see here, your overall brain volume, what the normal range of brain volume is, and where you lie for your brain volume compared to age match control. So similar people like you who are healthy, who and what their brain volume is. And so you can find out that, for instance, in this patient, their brain volume is at the 8.5th percentile, which means, more than 90% of healthy patients have larger brain volumes than this patient individually. And it can track this volume change over time. In this case, this patient appears to have lost approximately 1% of their brain volume in a year. And so this kind of information can be very helpful, but it's important to note that there are a number of limitations to the current state of brain atrophy analysis through these kind of programs. The issue is that getting accurate volumes is quite hard, right? Image quality needs to be very high, and any motion at all causes lots of issues. And obviously, it's very hard for people to stay still in a scanner in the first place. Atrophy measures can be affected by a ton of different things. The time of day that you get your brain scan will change things, because throughout your day, your brain is actually shrinking slightly because you're walking around and it's just kind of removing some fluid. It is affected by how hydrated you are, as well as many other factors. And if you want to follow brain changes over time, the best practice is you need to have every single scan you do on the exact same scanner using the exact same technique. And that's not always possible in busy radiology departments. Sometimes we update our scanner, we put a new one in, we take the old one out, which makes it difficult. We may update the software, and all of these things can have small differences in the way your brain volumes are calculated. So it's hard to compare brain volumes between different scanners, for instance. But there's a lot of reason to be positive about the future of brain volume analysis. The technology is really improving, and it's improving really, really rapidly, especially today with a lot of new AI technologies. We have faster sequences, which are making it easier to get scans with less motion. We're actually even having sequences that can correct for the motion immediately during the scan as well. And we're doing a lot of work to correct for various factors like time of day, like hydration, like being on different scanners. So currently, volumetric imaging is helpful, but it isn't perfect, and you do need to interpret results with caution. If you're looking at your results on 2 scans, and you had your images done on 2 different scanners, the calculated brain volume change over that time isn't as accurate as if you had the scan done on the individual scanners one at a time. So, in conclusion, hopefully this talk has shown you why MRI is the imaging tool of choice in MS. I hope you've learned a lot about contrast and how we should be using it judiciously, only where it will have the most chance of benefit, so it isn't necessary for things like routine follow-up imaging. MRI safety is really important, so make sure to answer those screening forms accurately. Make sure you have hearing protection is put in place correctly with that finger rub test. Remember, lesions are best seen on T2-weighted sequences, STIR sequences, which are fat-saturated sequences or proton density, while T1 imaging is more for brain structure and specifically for looking for contrast enhancement, those areas of acute or active demyelination. Remember the diagnostic criteria for MS and the idea of looking for dissemination in time and dissemination in space, and the classic imaging features like Dawson's fingers and corpus callosal involvement, et cetera. The central vein sign and peripheral rim lesions will become more commonly used in clinical practice as they move out of the research realm, which should help improve accuracy of diagnosis and getting patients diagnosed quicker so they can get started on treatment quicker. And atrophy is becoming more and more accurate over time, but it's still not perfect. Thank you so much. Really appreciate everything.
Awesome. Thank you, Dr. Honce. We did have some questions submitted, so I'll start with the ones that were submitted live. If you end up having sacral neuromodulation for bladder dysfunction, is it still safe to get MRIs?
Great question. So it depends a little bit on what stimulator you have and when those stimulators are placed. If you have a device like that, the most important thing that you can do is you can keep your implant card and have, so you can tell your radiology team, the technologists, the schedulers, what specific device you have. What our radiology team then does on the background is we look at the specifics of that device and we find out from the manufacturer what they say in terms of can you have a scan or not. And generally speaking, for sacral systems, some older systems, the rules are you can scan the brain using a special type of coil, but you can't scan the spine, while other ones say you can scan the whole thing, it's totally fine. Even in select cases where the device may say, hey, you can only scan the brain, you can't scan the spine. Here at Anschutz, we have some really great physicists, and that we have some kind of special ways we can sometimes do it, but we kind of reserve those for really, really important cases where the information is really needed, because there's still a theoretical risk of causing damage in those cases. But generally speaking, if you have a sacral neuromodulator, you can definitely get a scan of your brain, as long as we know that it's there so we can do the scan appropriately.
And does steroid treatment of a flare change your MRI scan?
So to some extent, so like a steroid treatment, right, helps reduce inflammation, right? So the typical result of getting steroids early in the course, maybe before your MRI, is it'll make the enhancement go away quicker, right? So while the T2 lesions, so the little bright T2 things that you see, those don't change very much just because of steroids. But if your lesion was active, there was acute breakdown of the blood-brain barrier, and you got a good dose of steroids ahead of time, but then got a follow-up MRI down the line, we may not be able to see that that lesion was enhancing. So we might just say, oh, they're all non-enhancing, and not realize, oh, that one was actually enhancing. It was just treated with steroids.
Um, on the subject of kind of what changes on MRIs, uh, what does it tell you when you get multiple scans and the lesions seem to change shape and size? And can you tell, or let's start there. Yeah. What does it mean when they change shape and size between MRIs?
It's tough. So those T2 flare images that I showed, right? So those are those images where you can see the lesions really well, but the CSF is all dark. We kind of remove that. Depending on the scanner that you got it done on, let's say you went to Anschutz one time and you got a scan there, you went to another place, maybe at Porter or Swedish, et cetera, and you may get a scan there. These scans, there's different parameters for each individual sequence, and small changes in those parameters can sometimes make fairly large changes in the way a lesion looks. So if I'm, as a radiologist, looking at a scan, I may look and say, hey, I can see the lesions better on this scan than I can on that scan. I can still see them on both sides, but they're easier to see on one and not the other. And often that's just due to changes in the kind of parameters of the scan, depending on how that scanner was working, what specific parameters were changed that can really change the way they look. If though I look at a scan and I say, hey, this lesion over here was really, really small now, and now it's bigger, right? And I'm convinced that I'm really truly seeing that change, and that change is real and not artifact. Then I can say, okay, it's bigger. That must mean that there is ongoing inflammation happening in that lesion, and it's slowly enlarging over time. That's something that actually is not infrequently seen in patients with secondary progressive MS. So MS over long periods of time when you stop having relapses. Even though you stop having those acute relapses, some lesions will just slowly be enlarging over time. And when they're enlarging over time, you're kind of confident that they're truly changing. If lesions get smaller, and again, if I'm convinced that it's not just a technical difference between the scans, that means reparative processes have been happening, and your body is trying to fix those lesions. But it can be tough. The change in size of those lesions on like a T2 flare can also be a change in the T1 black hole characteristics. So maybe they started out really, really dark, and your body's trying to repair them, and so they become less dark. But it can be difficult just because of the differences between different scans.
And that actually leads me right to the next set of questions, which is, what does MRI tell us about the progression of my MS, or what can the location of lesions tell us about the symptoms?
So the like the reason we get yearly or every other year MRIs is because we want to see if the disease modifying therapy that you're on is working, right? And the way we first look at that, and the way we've been doing that for years, right, is just looking for new lesions. If you have new lesions or your lesions are truly getting larger, that indicates that your disease is progressing over time, right? That the medication is not able to stop the development of those new lesions. So that's kind of like the main way MRI kind of says, hey, are you progressing in terms of new lesions? Now, just because you're getting new lesions, that may or may not correlate very well with your clinical or physical disability, right? So there is sometimes a disconnect between the way an MRI looks and how debilitating the symptoms you might have, right? And this is actually called a radiologic clinical paradox. Like you can take two scans, one patient has a lot of lesions, one has a little lesions, and that doesn't necessarily mean that the patient with a lot of lesions is clinically worse than the patient without. And one of the reasons is because brain atrophy is also affecting the way you do. But brain atrophy, as we talked about, is something we can measure, but it's hard to do so really, really well. And really, you want that combination of atrophy over time and the development of new lesions to get a sense of just how much you're progressing. So even though you may not have new lesions, if your atrophy measurements when you're getting scanned on the same scanner show atrophy rates that are higher than, roughly speaking, 0.2 to 0.4%, that might suggest that you have ongoing neurodegeneration that's happening that isn't resulting in new lesions, but may still be causing physical disability.
And on the subject of discussing things with the doctor, we had a couple questions. What types of software assist with measuring the brain atrophy? What should I be asking my radiology team if they're using the software? And then what questions should we be bringing to a neurologist based on how to better understand the MRI?
Yeah, I think those are great questions. So I showed you one example of a report for brain volume analysis in my talk. That was from a company called Icometrics. There's a bunch of different ones. Probably the most common word you may have heard when it comes to volumetrics is something called NeuroQuant, which is just another company that has their product, and they're one of the first ones. So there's lots of different software out there that all do very similar things, which is take those T1 images that we obtain and usually the T2 flares, process them in the cloud, and they can break down and say, okay, your whole brain volume measures this, your gray matter volume measures this, your lesions measure this. And if you were done on the same scanner with similar sequences, it will also say, there'll be a line in there that says, hey, the atrophy between point A and point B was 0.2%, 0.5%, et cetera. So you can see where you are. And all these reports, regardless of what they are, will also put your values onto a scale so you can compare yourself to normal healthy controls to say, hey, I'm way at the bottom, I'm in the middle, et cetera, for where things are. So all that information can be useful. So if you want to ask your doctor if they're doing like atrophy analysis, you can ask them, hey, was there automated atrophy analysis done? You could use words like NeuroQuant or Icometrics, but most neurologists these days do know about kind of these products. At Anschutz, we do volumetric imaging pretty much on every MS patient we can. Every once in a while it gets missed, but we can always go back and send those images for processing if it got missed in any individual case. In terms of things to talk to your doctor about, that can vary a lot, kind of depending on the situation. Like if you have a scan that isn't a slam dunk, right? So we saw the Dawson's fingers, the classic imaging appearance. If your scan isn't classic, right, and your doctor's saying, hey, you have some lesions, maybe you have MS, maybe you don't, we're not really sure. One thing to ask is, can we do a specialized MRI scan using things like the central vein sign in order to increase our confidence in MS? And like at Anschutz, if the neurologist wants to do that, they can request hey, do central vein sign imaging, and then we'll do that. We don't do that in every patient because it means more time in the scanner, which is not something we want, but we do that when they want to, and then we can look at those images, et cetera.
Regarding the dissemination in space criteria, wouldn't that require that scans include the spine and not just the brain? Why would just brain scans be ordered when assessing for MS?
Great question. So there's two reasons you may. So one thing is on those sagittal images that we acquire through the brain, we actually always get the top of the cervical spinal cord. So we get like the top half of your cord. So we do see the cord a little bit, but it's not perfect. But we see a little bit. So if you have a lesion up there, we'll even see it on a brain scan. Part of the reason is so generally speaking, for a typical MS patient, only 1 out of every 10 new lesions will cause you symptoms. Because the brain is a very complex network, and even if you interrupt one axon here, there's 50 different ways to do the same thing. And so you're less likely to have relapse with just a tiny individual new lesion. In the cord, right, you have a tightly packed highway of nerves, and pretty much every lesion you get is going to cause symptoms in some way. So depending on your symptoms, if there's really no signs that are specific to your spinal cord, you may not need that. And honestly, in most patients with MS, if you have any kind of classic disease, you're going to have lesions in the cortical or juxtacortical white matter, the periventricular white matter, and or the infraterritorial, so the brainstem and cerebellum. So often we're going to meet dissemination spinal space and time even without the cord. If you looked at the brain and people are still convinced you have MS, but you don't meet dissemination space, we can then do an MRI later on of the cervical spine to confirm.
Wonderful, thank you. We did have a few more questions, but we are out of time. A couple of the questions that folks asked were mentioned earlier in the presentation. I know that was a ton of information, so I do recommend just watching the replay when we send that out. But thank you, Dr. Honce, for your time. Thank you, everyone, for your questions. And then make sure you're signed up for our email list for future events.
Thank you so much for the opportunity to this. It was great. Hope everyone has a great Christmas and holiday, New Year, etc. Take care, everybody.